Thank you, everyone, for being here. We do have a couple of folks that are joining us online today, and we have a couple of noticeable absences. Melissa got called away to Chicago, and Marin is in New York meeting his son's future in-laws. And Becky got called away for some legislative stuff. It is that time of the season. So, but we are expecting a few more folks, and we feel fairly confident that we are going to have our quorum for voting today. So a couple of folks will be joining us online. Ronan's going to keep track of that for us. And as I said, an abundance of caffeine and sugar is available to you in the back of the room. We'll start with some introductions, and we have a number of guests, so we thought we'd go ahead and let them introduce themselves as well. But why don't we start with consortium members, and Brian, yeah, I'll just give you this mic and we can.
Pretty loud. Brian Beringer, Oregon Medical Association.
Dave Kohler, Dean of Instruction for Health and Public Service at Road Community College.
Cheryl Cohen, she, her pronouns, Traditional Health Workforce Manager at Pacific Source Health Plans.
Robin Moody, All Smiles Community Oral Health.
Jana Bitten, Oregon Center for Nursing. I'm not sure.
I'm Adrian Bennings, the president of Portland Community College.
Hi, Neelam Gupta, Director of Clinical Supports, Integration and Workforce at Oregon Health Authority.
Good morning, Rob Winningham, Western Oregon University.
Hi, Heather Ray, Project Director at Oregon Council for Behavioral Health and guest of
Heather Jeffress. Heather Ray is my official alternate for this evening, so thank you. I'm Heather Jeffress, Executive Director at the Oregon Council for Behavioral Health nonprofit trade association representing agencies that provide health and substance use across the great state of Oregon.
Hi, everybody. I'm Liz Rain, and I am the Career and Technical Education Health Sciences Education Specialist over at Oregon Department of Education.
Does that all fit on one business? And Jennifer Purcell, Director for Future Ready Oregon, and supporting you all as we're in the process of hiring the next healthcare consortium strategist. So hopefully you all saw the announcement that I sent you, I think just yesterday. And so please do share that with your networks. I'm going to go ahead and bring the microphone back here so our guests can introduce themselves. And we'll start at this end.
Isabel Dryden, Western Oregon University. I'm Director of Behavioral Health.
Hey everyone, my name is Jennifer Rice. I am a workforce industry specialist with the HEC. I'm here today with some interns that we have at the HEC from the Oregon Commission for the Blind. And I just want to say that one of our interns is very, very into behavioral health. So, and she wants to go down that pathway. So if any of you want to be network partners for her, her name is Daniela and she's right here and she's about to introduce herself.
My name's Stephanie. I am a job coach with Trellis.
Hi, I'm Daniela. I'm an intern at HEC.
My name is Chad. I'm also an intern, or sorry, I'm also a job coach with Trellis, working with Danny and Emily.
Hi, my name is Emily, and I'm an intern at the HEC.
I'm Bob Bellamy, just a member of the public.
Denise Roshto, Ant Farm Youth Services.
Good morning. I'm Denise Dahlman, she, her pronouns. I'm Assistant Vice Provost for Workforce Capacity Development for OHSU.
Rick Allgaier, Oregon Center for Nursing.
Good morning. Good morning. I'm Shelly Hodson. I'm a policy advisor at the HEC.
Right. And just a correction, we are never just a member of the public.
Good morning. Chloe Vignola, Program Manager of the OHSU and MA programs at United We Heal.
Andy Friedman, he, him, his pronouns, Executive Director, United We Heal.
Maeve Hayden, she, they, QMHA Program Manager for United We Heal.
Shauna Tice, Technology Industry Consortium Strategist.
At the HEC. All right, thank you. Did we have anyone else join us? We did.
Hi, Melanie, also with Business Oregon.
Thank you for being here. There is plenty of coffee and refreshments in the room. All right, well, we have a full agenda today, and Dr. Bennings, any opening remarks? No, just dive right in. Okay, super. Well, we will start with our consent agenda. You all should have a copy of the April 22nd meeting minutes in your pocket. Ronan, how are we doing on quorum? We're at 11. So, okay. So we will hold on the consent agenda until we have one more person join us online. But do take a minute to review the meeting minutes if you have not done so already. Certainly, if you have any edits, you can bring those to our attention now. All right, seeing none. Do we have anyone registered for public comment? Not at this time. All right, well that was quick. All right. Do we have Sarah Foster with us online yet? No. No. Okay. Well, I'm going to walk us through the agenda so that you all know what to expect today, and hopefully we'll have a couple more folks join us while we do that. Thank you, Ronan. So we're going to start with an update from Sarah Foster in the governor's office. Sarah's going to share updates, including information about the governor's new Behavioral Health Talent Council and how she is envisioning the work of this consortium connecting to the Behavioral Health Talent Council. She'll give us an update on how that work is going and the timeline for that. We will also hear from HEC's Legislative and Policy Affairs Director, Kyle Thomas, for some updates as we near the end of the session. And where we're at with budget and other legislative priorities. You met a couple of our panelists during introductions, but we are really excited to have the folks from United We Heal Training Trust with us today to talk a little bit about their programs, both in the CNA and MA and dental assisting and phlebotomy programs in partnership with OHSU, and then also their behavioral health programs, QMHA, CADC, and QMHP. And those all just roll off the tongue. So looking forward to that. They have a presentation to share with us, and then we'll have the opportunity for discussion and some moderated questions as well. We'll take a short break, and then we will dive back into the occupation profiles and wage data discussion that we have been having for probably the better part of a year now, but we really had the opportunity last quarter to dive into some drafts of the profiles and talk a little bit more about their use. And so we're excited to share with you how our thinking has evolved as we've received feedback across all of the industry consortium. And then you have in your packets the full draft packet for healthcare that includes the profiles for the high demand, high wage occupations, and then a full data table for all high skilled occupations in the healthcare sector. So hopefully you've had a chance to look at that before today, because it is sizable packet, and we'll be reviewing those, discussing those, moving towards adopting those for publication. So that will be the sort of the second half of our meeting today, and then we will wrap up by noon and get you all back on the road. Ronan, how are we doing online? Okay, let me text Sarah Foster. Everybody stand by and refill your coffee.
Oh, yes.
All right, I just got confirmation that we now have a quorum. We have 4 members joining us online, so we can go ahead and move to approve the meeting minutes if there aren't any adjustments to the meeting minutes. Did folks have any edits or amendments? All right, so I've got Brian, Dr. Bennings, and Robin Moody, and we're going to practice our cards. If you agree with approving the minutes as presented, please use your green card. If you have questions, yellow. If you are a no, red. Okay, excellent. Thank you very much. We will approve the meeting minutes by consensus. And we still do not have anyone signed up for public comment. I think we are past the public comment time. So if Sarah Foster is with us, I am getting a thumbs up. We will turn it over to Sarah for updates. Are you able to put her on the screen? Great. Welcome, Sarah.
Hey, can everyone see and hear? I can see myself on this very big screen.
We can see and hear you.
Can you hear me? Okay. I'm so sorry I can't be there in person, but was glad to be able to join this morning. And I think, Jennifer, my task is to update everyone on the Behavioral Health Talent Council and talk about ways this group can engage in that work, correct?
That is certainly on the agenda, and any other updates from the governor's office.
Well, I don't have any updates other than we are nearing the end of a very long legislative session. I know many of you are all feeling the fatigue as well, but I know that we are feeling it in the governor's office, and just know there are many people in the room that have played a role this session to advance myriad of the governor's priorities. So just thank you. I know it's been a hard session and a lot of hard work. And I know that that many of you are feeling that fatigue. So here with you on that. But meanwhile, I just wanted to kind of share kudos to, I think back in January, you heard the Behavioral Health Talent Assessment Summary, and just wanted to bring everyone back to the work that the governor's office asked the HEC to do is commission that assessment, and think that it was just one of the governor has one of the best, I'd say, workforce assessments that she has seen, and is really energized around both the integration of the education and training data with the workforce data. And so again, just wanted to thank many of the members here that provided their expertise on the steering committee, lent expertise in their data, and just think that without you all guiding that project, I don't think we would have such a successful report and recommendations to work with. So really kudos to this group and the HEC leadership for getting that done. Now I think our question and our task ahead is how do we implement those recommendations? There are, I think, 60, I don't remember how many recommendations, but there are upwards of 60, and know that we can't work on all of them at once. So the governor's office is convening the Behavioral Health Talent Council is what we're calling it. That's going to create a roadmap for how we're going to implement the recommendations across both the education and training system, but also licensing and credentialing and recruitment and retention, in particular in some of our highest need industries. So in particular, our community mental health providers that are providing kind of critical care for our Medicaid population. So it's a very comprehensive task force or council that's going to take a look at the recommendations that are coming out of, and using this assessment as a guide to come up with that roadmap by the end of the year. I'd say that I know that you all were thinking about convening a work group around it, and think that there's still that opportunity. One of the work groups out of the council will be the education and training pathway work group, and the HEC is really leading that work. And we are going to kick that work off this summer, and are going to organize I think there are like 36 recommendations assigned to that work group. And we're going to start to prioritize those recommendations and create action plans, and see the opportunity for this group to really lean in on areas in which the council may not prioritize, or take some of the prioritized recommendations and go a couple layers deeper. So I think more soon on that process. We're just kicking that work off. The council just kicked off a couple weeks ago. We're having another meeting this Thursday, but it's really just been getting the council up and running, establishing those work groups, but and want to name that our intention is to not duplicate the work that you all are doing, but add value by convening kind of a broad set of partners in behavioral health, and identifying those areas of opportunity and alignment. So that, I think, is my update. I don't know, Jennifer, did I miss anything? You've been an active participant, and just want to thank you and the HEC for doing a lot of the legwork to get this report to the finish line, and staffing that education and training pathway work group.
Thank you, Sarah. Sorry for the feedback. I think Ronan's adjusting the microphone. Appreciate you being with us. I would love to just open it up to the council in case consortium members have questions for Sarah. There are microphones on the tables we can pass around. Do folks have questions about the Talent Council, or more specific questions about how we may connect with that work? Yeah, Heather, you got that one? It probably needs to be turned on. While Heather's grabbing that, you met Shelly Hodgson during the introductions back here. She's my partner in crime. So she and I are working on the education and training subcommittee and supporting that work that Sarah mentioned. Go ahead, Heather.
Oh, sorry. Hey, hello, Sarah. How are you? Heather Jeffress here from Oregon Council. And this might be for Jennifer too. Is it to be unfolded? Kind of how the HEC and the subcommittees of the task force, or the task force as a larger entity, are gonna, or do you have a kind of a vision of what that might look like, or is it too early to know? I don't
I
know.
think I missed that crucial part of how, could you ask the question again? I think you cut out.
Oh,
for a
just
bit.
curious a little more on like, is there a vision, or is it too early and it needs to unfold about how our HEC work will coordinate with the task force and the subcommittees? Is there a little more detail about that? If it may not be ready yet, I don't know.
Yeah, so I'd say that still to be determined. So the education and training pathway work group out of the Behavioral Health Talent Council has about 35 recommendations out of the talent assessment that has been assigned to that work group. And our first task in the talent council is to go through a prioritization exercise, like high impact, high feasibility, low impact, high feasibility, a general prioritization framework. And from there will be the opportunity, I think, to see the alignment and see where this consortia may lean in on some of those recommendations and go deeper, or where the council itself is better positioned to lean in and go deep on recommendations. I see the HEC and this group as really leaning in the education and training pathway and the HEC sphere of influence. And I think there's also a licensing and credentialing work group that some of the licensing boards are leading with the governor, and a recruitment and retention work group. And so they have other recommendations out of the council assigned to them, knowing that the assessment was a broad look at the behavioral health workforce. And so I see once those recommendations, the 36 or so, are prioritized, I think we can look at them and this group can kind of look at them and see where there are gaps and where you think you all may lean in on your own work, or where you may see the opportunity to add value to some of those, I'm guessing like high impact, high feasibility recommendations. And so that's our first task, is to kind of get a handle on there are, 65 recommendations, 30 assigned to our work group. How do we prioritize? How do we make sense? And knowing that we don't want to be too diffuse with the implementation.
Thank you. You're getting a thumbs up.
I'm getting a good.
All right. Do other folks have questions? All right. I'm not seeing any other questions in the room. Sarah, thank you so much for joining us. We appreciate it.
Yeah, sorry I couldn't be there the whole time. Thank you. Bye.
Thank you. All right. I just got word that Kyle got pulled into a committee meeting. We're nothing flexible here today, but I do think we have our full panel from United We Heal. And so with their thumbs up, I think we'll transition to the panel. And then if Kyle is able to join us a little bit later, we'll squeeze him back in for an update. But with that, why don't I just invite our guests from United We Heal to come to the front. We've got some name tags for you, and I've got extra microphones. Steal your microphone. Oh, all right. Well, we'll just. Go ahead and take it away. And if y'all want to introduce yourselves, and I know you have some slides to share, and then we can facilitate some discussion with the group. Thank you.
Again, Andy Friedman, he, him, his pronouns. I'm the executive director of United We Heal. We do have a late substitution for some health issues, so we don't have this panel, but we have Maeve who will introduce herself, who's going to take that role. But it's good to see some of you who I've seen only in small Zoom squares. Life.
Good morning. I'm Chloe, she, her pronouns. I am the program manager for the OHSU Pathways and the MA apprenticeship at United We Heal.
Hi, I'm Maeve Hayden, she, they. I'm filling in for Sarah Drake this morning, and I'm a mental health associate program for United We Heal.
United We Heal was formed in 2021. So 4 years that we've been really ramping up our activity. We're focused on statewide accessible healthcare workforce development. So both in physical health and behavioral health. We have 4 programs right now, around 4 separate registered apprenticeship programs in the behavioral health space, a behavioral health pre-apprenticeship program in high schools. So we have 2 high schools that have participated this year, and we have 13 more that are going to be participating in the fall. And then with OHSU, 4 separate occupational pathways that we've been working on a HEC Future Ready supported grant over the past couple of years. And then we have a lot of these folks after completing their programs come back to us and say, okay, great, what's next? And particularly, as a lot of you know, in the behavioral health space, to move from a certified role, say as an addictions counselor, to a qualified mental health professional is a big jump. And so thinking really about how to make that jump sustainable is a big priority of some of the things that we've been focused on recently, about thinking about how to make more steps along that pathway. So we are a 501c3 nonprofit, and we're a joint labor management training partnership, which is, I think, an important element to who we are and how we're successful. And I think it feeds into a lot of what's going on in behavioral health with retention rates. So as a labor management training partnership, we're governed by RISA and by Taft-Hartley as in terms of the financial and governance requirements on the organization. Half of the trustees who run the organization are employer side representatives. The other half are employee or union side representatives. And that mix is really important for being able to solve problems. These are also folks who have longstanding relationships with each other in that sphere of thinking about not just what the training pathways are like, but what ultimately the jobs are like, and how to make sure that those jobs are sustainable and jobs that people want to stay in. And I think you particularly see in the behavioral health talent assessment that you saw that it's part of the issue is training folks for these positions. Part of the issue is keeping folks in these positions. And so a piece of that is making sure people continue to see pathways for advancement. And a piece of that is making sure that the working conditions in those positions are sustainable. And so really having that holistic view is a key difference, I think, between what we do and what some other training processes really do, because it really is about not just bringing together the education and the employers, but really making sure that workers themselves have a voice, and so that those programs are designed with workers' interests in mind. And then also that as things develop, that we really are able to work through some of the complications that come up with both the employers and the workers involved, being able to really have some say over what that looks like. We do have, of the 18 employers that participate in our programs, some of them are union employers and some of them are non-union employers. And we're currently operating in 15 counties in Oregon and have some discussions with employers in 3 or 4 additional counties right now. I want to say a little bit more about the role that we have as a labor management training partnership. In addition to that long-term relationship with stakeholders, We also provide some direct instruction for non-accredited coursework, which we think is really important for getting folks from an entry-level behavioral health role into a kind of first-level certified role. That we see those pathways really being very efficient to bring people to a point where they stay in the industry, they see a pathway for themselves for advancement, and really thinking about how we do that in that unaccredited space. We see that being really an opportunity for there being future accredited pathways that people really can build on in a more significant way. And so we really think that it is important for retention to really have that pathway, particularly for a lot of the participants who we work with who don't have strong histories in formal education, that this is really an easy opportunity for them to have a look at what that education pathway looks like and make sure that they have some confidence about their ability to participate in educational advancement. We also contract with other entities and coordinate with other entities for curriculum delivery. We have one of our apprenticeships, our QMHP apprenticeship, Qualified Mental Health Professional, which is a master's level mental health counselor. We have 4, I believe, counselors going to Western Oregon in the fall and starting that program. We also have a number of our behavioral health pre-apprentices who are in high schools where the full pre-apprenticeship curriculum is not available, who are taking those classes through local community colleges, which we're supporting. We, as a labor management training partnership, we're also involved in compliance with BOLI because BOLI runs apprenticeships. And this has been a real evolution, I think, for BOLI over the last few years to move from a very construction and utilities focused apprenticeship system to one that is more open to non-traditional occupations. And so we've been involved in a lot of that work of trying to figure out how to shave off some of the hard angles to make sure everything fits. But we are involved then in recruiting employers, and also a lot of case management, which we think is pretty important in terms of tracking progress and coordinating between clinical supervisors and pacing of the work experience people have so it aligns with the educational coursework so that as opposed to maybe a terminal practicum, they really are getting work experience all along the way and using that ongoing work experience to really more robustly develop and support what they're learning in the classroom so that there's more immediate transfer of knowledge. We also have some study halls and provide learning aids, particularly for a lot of our folks who raise disability issues, as well as financial services supports. So this model, we believe, is really important for engaging employers and engaging workers in the training outcomes and therefore in the training programs. And these folks really as long-term partners in workforce relations are able to work on resolving conflicts that come up in those training programs, in the implementation of those training programs, and in thinking about then what the next steps for folks are after those training programs complete. And it's also that because this is a multi-employer program, it's much more focused on the system holistically instead of just the needs of any individual employer or the needs of any individual employer at that moment. A lot of these employers really do not have a lot of resources and are very focused on their needs. This is a way to really allow them to participate when they need to, and not when they don't have that compelling motivation, but continue the organization and continue the availability of the pathway where it's most needed. We also are very, particularly as we're grant funded, particularly responsible to grant deliverables and being able to demonstrate really what investments result in terms of trained individuals. So a little bit more about our career advancement, career credit for prior learning. We think particularly with some of the occupations that we're involved in training around, there are not great career ladders. There aren't a lot of easy stackable, that the steps are pretty big. And we think that credit for prior learning really is an underutilized tool in Oregon that really has the ability to further support student workers, particularly adult learners, who have experience in the workforce. And you'll see some of what we've been doing actually with the State University of New York is looking at some of the experience that people have, both in terms of formal education, classwork, and work experience towards college level learning outcomes, and applying that to credit that is standardized and understood by applicants before they come into the program, so that they are really able to not have to repeat and not have to lengthen their studies with coursework that they've already really, and learning that they've already achieved. I'm going to turn it over to Megan.
So I'm going to talk a little bit about our behavioral health. We have registered a total of 299 participants across all programs. Right now, we're supporting 71 active QMHA, CADC, MA apprentices, and CBL students. We had 27 pre-apprenticeship graduates this spring. Our pre-apprenticeship graduates get a year towards their progress in the QMHA apprenticeship should they choose to continue. And we have a second cohort of 70 starting this fall. We have our pilot cohort that Andy mentioned a bit earlier of 20 qualified mental health professionals starting this fall at a few different universities. And of our 80 QMHA, CADC, and MA graduates, 63 of them are already credentialed and 17 are preparing to test or register. Right now across programs, we have a 65% completion rate, which we're very proud of. It's about 22% higher than community colleges. We find that students are motivated by career goals with only the necessary educational requirements, but there are a number of other reasons for that completion rate as well. When we think about what we can do to recruit people from priority populations and have them succeed, I think we found a lot of success in a program that kind of substantially alters the format of the education that's provided from the traditional pathways offering. We've heard from a lot of apprentices that not only is the fact that the pathway is free, obviously a game changer, but also if a life emergency comes up, they can take time off of coursework without having to drop a class and endure a financial penalty. That makes a really big difference to them as well. I think that and the fact that education is designed to work with the job rather than as something to somehow fit in, which can be especially challenging for disabled participants and or working parents, has made the experience just a lot more accessible. And we do a few other things to support them as well, which I'll talk about in a moment. Next slide, please. So a bit about equity outcomes. 79% of our participants, their highest level of education is a high school diploma or GED. So again, through that approachable and kind of accessible exposure to higher education, we've been able to reach a population that wouldn't necessarily otherwise pursue immediately. And we hear all the time from apprentices, I didn't think that I could do school, but this program has really increased my confidence. And now that I kind of know the ropes of higher ed in this super supported environment, I can go back and get my degree because I know that I can. 90% of our participants identify as a member of an underserved community. So we're defining that as BIPOC folks, LGBTQ+ folks, women, immigrants, veterans, individuals with disabilities, individuals in rural communities, individuals without a college degree, individuals recovering from substance use disorder, and justice-involved individuals. A bit more on identity. So 76% of our participants identify as non-binary or female, 58% as BIPOC or Latinx, and 19% as a person with a disability. So overall, our apprenticeships are substantially more diverse than the general workforce population of Oregon. Next slide, please. Thank you. So really quickly on the aforementioned other things that we do to support apprentices, supportive services, we've spent close to 200,000 on them, have been, I think, really key to our apprentices' success because it allows people to remain in the program when barriers arise. It's been super powerful to have moments where someone thinks that they'll have to drop out because something happened with their family, they can't afford emergency childcare, and then just be able to reimburse them for it, keep them involved, and then ultimately have them graduate. We're also able to offer stipended quarterly study halls where participants can come spend an entire day with us, meet each other, get peer support, work with program managers, and just kind of knock out whatever they need to do. And we've heard from them that that kind of extended, individualized, and interactive support has made a really big difference for people. And then we have a quick quote from an apprentice himself. So RL was enrolled in the program, but not progressing for a while due to having to finance a move that he could not afford with his high needs child. So we were able to help him pay for his deposit. That obviously took a huge stressor away. And once that stressor was removed, he just blitzed through the classes, graduated on time, and was immediately promoted at his workplace, Cascadia Behavioral Health, and is now even better able to provide for that kid. Next slide, please. So a little on challenges and the solutions that we've so far devised. So as Andy mentioned a little bit earlier, working with the BOLI Apprenticeship and Training Division, these traditional apprenticeships are in the trades and construction and utility. So it's been a bit of a lift of trying to put a round peg into a square hole, just with varying knowledges on credentials. And also there are many different ways to get these credentials, but when it comes to a registered apprenticeship, there must be one standard and one way. So kind of figuring out how to keep that flexibility and not erect unnecessary barriers just because of the structure of apprenticeships has been a challenge. Also, we did encounter some difficulty continuing to support graduate completion within existing higher education limitations because those traditional pathways, again, they require degrees that don't always recognize non-accredited education, work-based learning, and it can be a bit an apprentice, for instance, who has worked in the field for 10 years as a certified recovery mentor, has been leading like a men's support group the entire time, gets their CADC, is now devising and sort of like rolling out their own version of like an AA group for men, then having to be told that they need to, from 6 to 9 p.m. on a day that they have their kid take a class on men and addiction, and that there's no way around that, I think is a stumbling block, just as an example that people struggle to stay motivated in that environment. So our solution for that is, again, our credit for prior learning program. So we partnered with State University of New York. So our CADC 1 graduates will get 30 quarter credits heading in for that prior work experience. They also have the opportunity for additional portfolio-based CPL after enrollment. So again, if you have massive amounts of work experience, our average apprentice's age is 37. So a lot of them are quite experienced in the field, and you can prove that to the university. You may be able to get that credit for the work that you already know how to do. Yeah, next slide, please. So here is and contrast between the traditional CADC pathway through higher ed versus our apprenticeship pathway. And then we can, on the next slide, I'll talk about ways to integrate those. So traditionally, the CADC certificate is through an associate's degree. That's 90 credits. It's 2 years as a full-time student. During that time, of course, you have no or reduced income and probably some student debt. Many of these folks end up working for organizations that do qualify for loan forgiveness. So that's still about 10 years of work while you're paying on the debt in the meantime. So our apprenticeship, of course, we have people who are working full-time in behavioral health care while advancing their career. So both pathways lead to the same credential, CADC 1. Our pathway is 150 hours of learning, 1 year as a part-time student while you are working full-time. So you are able to keep your same job. Your work experience is valued. You need that work experience to get certified by the Mental Health and Addiction Certification Board. Anyway, so you're able to graduate the program with the full amount of work hours required and immediately become credentialed. There's no debt. It's efficient because we only require certification required coursework. So again, that certification board is only in state for certain classes. Those are the only classes that we require of the apprentices. And then, of course, there's supportive services for participants. The behavioral health workforce doesn't lose these workers. So workers appreciate it. They get to keep their job and their income. And of course, employers love it because they are getting to keep their workers. Excellent. So a community college opportunity. Of course, a formal degree is still valuable. As mentioned before, you need these formal degrees to engage in the progression that can get you to qualified mental health professional to that master's level counseling. So it is something that could be considered that upon enrollment, community colleges could think about adding a credit for prior learning opportunity for folks who have a CADC 1 or similar credential that would ideally be fully transferable to an applied baccalaureate. So again, CPL credits can recognize these unaccredited, but still Association for Addictions Professionals approved CADC 1 coursework and the work-based learning that they've achieved. Community colleges could consider providing coursework required CADC 2 as well in an associate's degree context with the ability to stack it towards an applied baccalaureate. Some other potential solutions are considering taking the gen ed requirements like writing, humanities, and math and embedding them in learning pertinent to the major. So like documentation, ethics, statistic, literature reviews, credit for ongoing work-based learning. I know many programs will require some type of documentation and medical records class. If you have been doing that documentation, been doing the work that the class prepares you for 4 years, having the opportunity to provide that and receive credit for it, I think would be very powerful. And then considering maybe some asynchronous content delivery to shift professional resources from lecture to problem-based learning, and seminar reflection on work to improve knowledge transfer. I have a participant now, for example, who dropped out of a social work degree, but is thriving in the QMHA program because they find that being able to take a psychology 101 class while working in care admissions and seated right next to a master's level clinician, they can talk through the concepts with them. They can really learn from someone who knows how to do the job while they're getting that classroom knowledge still delivered to them, and apply it in a way that purely theoretical classroom style learning was really just not working. And then lastly, thinking about providing an applied bachelor's that includes classes at the 500 level to better prepare individuals for an accelerated trajectory to pursue QMHP status. Because yeah, right now that pathway takes 6+ years in the traditional route, which is a very long time.
Thanks, Maeve. I'll be overviewing our OHSU program that I oversee in partnership with OHSU, local AFSCME 328, and Unite Oregon. We are a HEC Future Ready grant, so thank you all to those in this room right now for that opportunity. We're roughly about 2/3 of the way through this 3-year grant. The intention was to lean into OHSU's already existing as a teaching institution. When we planned this program, these 4 pathways, it sort of made sense to partner with such a large teaching hospital that's also a level 1 trauma center in the Pacific Northwest that lays the groundwork for a lot of accessibility for training, for partnership, for networking. So there's already robust onboarding that already exists for students. They are already deeply familiar in managing grants. And as well as transitioning from a student role to an employee role is widely accepted and understood, as many students, interns, and externs are placed at OHSU. And then our 4th partner in all of this is Unite Oregon for community outreach, which specifically outreach in BIPOC, marginalized, and typically underserved populations in Oregon. Our deliverable goal starting out was to have 83 participants move through this program within 3 years. We are currently anticipating 100 participants to move through and become certified as either a CNA, a DA, a CCMA, or a phlebotomist. This is great. It has been an overwhelming response from the community. We have had just over 1,400 applicants to the program itself. We move through these applicants in partnership with the local 328 union to ensure accessibility and equity within the application process. This kind of allows for not just OHSU, not just the union, but a tandem choice in who gets to move through this program. We also specifically in our work with Unite Oregon and with Local 328, our priority population deliverables have been met. We are looking right now at 48.7 identifying as BIPOC or Latinx, 38.3% identify as LGBTQIA+, and just over 76% identifies female, transgender, gender variant, or gender nonconforming. So far, 39 participants have graduated and or certified. 26 participants are currently moving towards completion. Our dropout rate is just 4 participants who have withdrawn from the program. 3 of those were given an opportunity to attend nursing school, which is a great reason to leave a program. And 1 just struggled with program completion because it is still clinical and full-time school, which can be quite the burden. Some quotes from folks who have moved through the program, as well as those pathway leaders that we have at, that are situated at OHSU. This first one is from Phil Rourke, who's our phlebotomy pathway leader and teacher. He helps move all of the phlebotomy students through the program. So he states, we are getting the education and clinical experience at the same entity, which is essentially unheard of. This program offers both teaching and certification and clinical experience all at OHSU. We do not have to place we do not have to place people into specific outside clinics. It is all done internally within OHSU. There's no looking for an externship for 500 hours for your summer that's unpaid. It's all internal and it's all paid work, either through wages or stipends for each individual. I have 2 quotes here from 2 individuals who have moved through the program, graduated and certified. This first one, Agartha Pourmore, she is a dental assistant who is recently certified, our second cohort of our DAs. So when she moved to this country, she attempted at taking PCC prerequisites, but coming from a developing country and taking care of her family back home, she was going to schools for many years and it was too much to do a traditional pathway. So when this opportunity came about with OHSU, it was the best thing for her, and it was the most helpful and accessible program out there for her to be able to come back to school and gain her dental assisting credentials. Secondarily, here we have Claire Hansen, who just recently graduated as a CNA and passed her certification. Specifically, she wanted to join the Building Bridges program because at OHSU, it's working in an environment that pays for you to go to school and has a pathway for professional development. Was really important to her. And also the partnership that OHSU has with the Local 328 union is something that was very important to her, something she's very passionate about, having that representation from a union to ensure equitable access and outcomes for the workforce. She was very excited about that portion of the program. So these are some of the challenges, of course, working with a large, widespread hospital, of course, is a big bureaucracy. So there is a need for dedicated staff. There is a need for somebody to essentially shepherd through all these folks coming into the program who's interested in the program. And in addition to that, each of our individual pathway leaders have been also phenomenal in shepherding folks through the program in just terms of support as far as one-on-one mentorship. Moving through the curriculum, making sure people are meeting their check marks throughout their curriculum and throughout their clinical experience. Another struggle we are looking at currently is the employer time horizon. So essentially, someone moves through the program with the CNAs, and OHSU itself might not have a ton of CNA openings at that point in time. The inverse of this, of kind of the solution we had for this program, was essentially because OHSU is so involved, and as well as the Local 328 union, we were able to have enough networking opportunity to bring those CNA graduates into other jobs. So even though we are not returning them back into their OHSU setting, they're still going back into the Oregon workforce and finding employment, which is wonderful. Another hurdle is kind of changing the culture of training and education at such a large teaching hospital. So right now, currently at OHSU, a lot of the teaching and training pathways are centered around your medical students, your PA students, your nursing students, and the flow for them to go to OHSU as a student and then move into OHSU as an employee is a well-versed and long time standing tradition at OHSU. And so we're looking at how can we move this down so it's more accessible to allied health roles. How can we apply this same model to the certified medical assistant who moves through this program and they immediately have that job opening to employ into? And lastly, essentially, how do we use this foundation of education to be able to accelerate to the next pathway for folks? So a lot of the times, a lot of these allied health pathways can kind of seem like the end all be all for a lot of folks. They look at becoming a medical assistant, they look at becoming a nursing assistant, a phlebotomist, and then the big question is what's next for these folks? A lot of folks, it can be this higher education of MD, PA, NP. A classic transition, of course, is CNA to RN. There are plenty of folks who have moved through this program, however, who have expressed interest in those high need roles in healthcare and allied roles, your radiologists, your surgical technologists, these allied health for better longevity for wages and retention of employees. So our slide, I think, sorry, thank you. Our proposed solution to this is kind of taking a look at how can we utilize this experience of being an MA for so many years, of being a phlebotomist for so many years. How can we utilize those experiences when this person is, they're studied in medical terminology and clinical operations in anatomy and physiology. I think writing 121, everyone has to do scribe work. So these are all obtainable skills that they have experienced in clinic after working for even just a year. And how can we apply this into a community college recognized of CPL credits? And so our proposed solution essentially is, for example, taking an AS in radiography that recognizes work-based learning. And what is also quite valuable about this situation is when you have individuals who have been an MA or a CNA for a year, 2 years, or sometimes longer, they are learning invaluable experience that is difficult to teach at the educational model. I think of things, just myself being an MA for so many years, I think like clinical bedside, clinical operations, these are things that you learn when you're out there in the field. You can't exactly, I feel like you can try really hard to teach clinical operations and bedside manner in a classroom setting, but it doesn't quite click until you're there and you're talking to the patient and you're moving through clinic. So these make these folks extremely valuable students who will come in with just a wealth of knowledge, which I think also will speak a lot to retention throughout the programs.
If you want to, I don't know if folks have questions or.
Well, you answered most of my questions, which was great. But would love to open it up to consortium members for questions. This was such a great overview, the opportunity to hear the work that you're doing both in allied health pathways and in behavioral health pathways, and the things that you're learning about opportunities for acceleration strategies in both of those. But consortium members, questions for, and I'll pass. Okay. Who raised their hand? Robin has the mic right in front of her, so I'm going to let you use that one and I'll give this one to Rob.
Can you just reiterate how United We Heal is funded, please? Whether that's through HEC grants or HSU? Thank you.
Sure, there's a number of grants that we have. There is a HEC Future Ready Oregon grant that we have that is funding the OHSU physical health work. There's, over the last few years, we've had some Future Ready grants from BOLI for some of our behavioral health work. We're actually a sub-awardee on a HEC strategic SAEEI state apprenticeship expansion grant. that is wrapping up in about a week. There's some other federal grants, a number of grants.
Thanks.
It is very different from maybe most labor management training partnerships, particularly say in the construction environment, are funded by employer contributions on a kind of per dollar per head basis. And when we started this with behavioral health, the thinking was these are nonprofit organizations that are really struggling. Yeah, and they don't have a lot of money. And ultimately, where they get their money is fundamentally, these are Medicaid serving organizations. They get their money from the government. And so the idea of saying we should take resources from these struggling organizations to dedicate towards training was difficult and seemed a little bit artificial, because ultimately the grants are coming from the same source. And so it's a way of putting more resources into the Medicaid serving population instead of just, a zero-sum game.
Rob, before you go, can I ask just an add-on question? Are you concerned about sustainability of that model, and what are some of the strategies that you're thinking as grant funding sort of ebbs and flows?
Yes. I do think we've seen a significant change, particularly at the federal level, and a lot of the state grants are ultimately federal sourced. And so I think a particular concern. And so thinking about, we've been trying to think about different ways of diversifying some of the funding, but fundamentally, really, the training resources either come from the government entities that are serving those populations that think about how to take care of those populations, or they come from the employers, which in this case really is the same entity.
It was a really informative presentation. Thank you. I learned a lot about apprenticeships. My question's on the credit for prior learning. We've been working on this. There was some grant funding that had been available. It was hard to do. And I wonder if you could tell us some more about success stories with credit for prior learning. What factors made the credit for prior learning experience better for students? Any suggestions for higher ed institutions?
Sure. I think so. SUNY, State University of New York Empire, really has been doing this for a long time. So it might not be fair to compare them to anyone else, because they have, a good 30, 40 years of experience doing this. But what they really do is kind of a two-track CPL process. The first piece is that they have standardized assessments for credentials. And so they looked, for instance, at our CADC apprenticeship, and then they looked at the learning outcomes, both in terms of classroom and work-based learning and credit value, so that students know before they even apply what they'll get for that CADC, and they know what they'll get for the QMHA apprenticeship. And then after they're in the program, they have the kind of more traditional portfolio-based opportunities for individualized CPL, so that they can look at to what extent do they already have, say, the writing, the math, or maybe on the physical health side, maybe they have medical terminology or other elements, biology, that might be expectations on the front end that they frankly can already meet. And so I do think that they're really thinking about the two-sided process, I think is pretty important. And that it's a level of proactive focus that I think really would serve institutions well. It's also, I think that the Pacific Northwest Regional Accreditor has recently opened up their CPL requirements, and that was some of the impetus for some of the focus on CPL. And so looking at what percentage of the degree comes from CPL is a big change. And so at SUNY, their limitation is much higher in terms of how much of the CPL can meet degree expectations. And so thinking about not just how to kind of give credits, we have an example of our CADC2 on staff got an applied baccalaureate from Chemeketa, and she talks about how many elective credits she had, that 150, 160 elective credits. she didn't need all those elective credits. Thinking not just about how to give credit, but how to give credit in ways that are actually valuable in terms of shortening folks' degree pathway, because you're really thinking about what learning outcomes towards the major are being achieved. And I think it's a level of flexibility about thinking beyond, for example, writing 121. And it is, to that extent, I think there's really a larger conversation about to what extent do we need some of these very formulaic expectations. If the need for a medical assistant is documentation, and that's writing, do we need them to write essays? And maybe if they want to become a nurse practitioner who's involved in research a few years down the road, they will need it, but they'll need it then. And instead of making everyone get through all the hurdles on the front end, thinking about really what are the hurdles they need to accomplish to do the job you're training them for, and how you meet expectations around gen ed requirements that really can be embedded in the occupational activity that they would be engaging in.
Thank you for your great presentation. I have, I'm going to ask one question. I'm not sure if I'll mention the other one, but my first question is, in what ways, beyond completion, you mentioned some completion targets, are you tracking job placements and or progression because of the success of your program? And how are y'all doing that? And if so, can you share a little bit about the placement rate, success, and that sort of thing?
Because they're so, and both. These are programs that are embedded in the work-based learning. These are jobs, they're apprenticeships.
Is there progression that comes from, or is just to advance the skills primarily?
So for all these folks, they are already working.
Right.
And so job placement is 100%. They're in those jobs. There might be
school. So with the high school program, do you have a high school pre-apprenticeship too? So how do you track? I'm just curious, how do you track those cohorts through the program as well? Because they're not working. Yeah.
Right. The high school pre-apprenticeship is, I think fundamentally we see that as an important element to expanding the behavioral health pipeline. That if you think about a traditional health exposure course, health careers exposure course in high school, it really focuses on, you can be a nurse. If you want, you could be a doctor, or you might want to be a CNA, but it really does focus on a very limited subset of health careers. And it really does that to a significant exclusion of behavioral health. And so this is really about getting people interested in behavioral health earlier, getting people to think about it, but also thinking with an eye towards all of the mental health issues that are going on for adolescents right now, that if you're bringing that curriculum into the schools, you really are creating more opportunity for more healthy conversations within those schools about mental health issues. What we've seen so far, this is our first, we've just wrapped up our first year. I think we had 25, 26 folks who completed the program. A chunk of them, 4 or 5, are going on to the OHSU Balmer Institute. We've got, and beyond that, I don't have a lot of data right now on where some of those other folks are going, but I think it's something that we're starting to look at, and I think after, probably by July, we'll have a sense of where some of those folks who haven't maybe made decisions yet are going to go. But it really, that is not intended to be kind of a career placement. It's really intended to kind of open up doors, and have people make some choices about and be maybe more informed. And so a big chunk of what we do in that behavioral health pre-apprenticeship is also some career exposure opportunities, so they can see some of the various opportunities that exist in behavioral health and see those occupations a little more robustly. And then also some workplace preparedness, so helping people to actually function in a job, even if it's not in healthcare, but just kind of understand the work environment in general. But it really is not intended to be kind of a direct placement program.
And these are relatively new programs. Now, we don't have a whole lot of time under the belt, but you have the structure in place to track I would imagine, college and career placement, career progression, wage progression over time.
Yes, although these are 18-year-olds who are gonna give us the data they're gonna give us. In many ways, the apprenticeships have much more robust ability to track data because we not only have the existing employment relationships with them, we also have the employer reporting. And because this is a labor management training partnership and we have the union data that spans multiple employers, when we see somebody who is in a program and leaves, we often see them show up in another employer that have more opportunities to see some of that data on the apprenticeship side.
Do you use social security number to follow employment and wage over time?
It's an interesting idea. We'd have to look at what extent we can do it.
Okay.
So I think I see this, first of all, thank you. I see this as a three-legged stool where you've got funding, where you've got employment, and you've got accreditation. And in all of those, you've got some barriers that you've overcome, like barriers to entry, like your funding. You know, helped your students overcome the barriers to entry for funding. But my question is, what does it cost, even if it's a grant? What does it cost to move a student through your program? Because if the funding goes away, that's a key data point for anyone who might want to adopt this. Do you have a sense of what it costs a student to move through from beginning to end?
Yes, I think that particularly the fund right now, given what's going on the federal level, is particularly concerning for all of these occupations. Fundamentally, when you have a 90 credit associate program and 150 credit, 90 credit, and I'm sorry, 15 credit training program, it's less. It's less because there's less time. And I think it depends on which pieces you're.
Approximately, like just give a ballpark, like if you were doing the 90 credit, if you were doing this, like what is the cost per student from beginning to end?
So if we're focused on tuition alone, the QMHA and CADC level one-year programs are around $2,000 in tuition costs. But I think that leaves out the advising and it leaves out the supportive services.
Which I saw was a big percentage. So in totality, are you talking 2,000 to 5,000, 2,000 to 10,000? What's your range?
I would say when you include supportive services, you include clinical supervision that employers are doing, but you don't include wages, it's 2,000 to 5,000.
Okay. And I think that would be a key data point as you do this presentation is the cost of the student to move through a program. Because if someone wanted to adopt this model and funding was drying, funding is a big piece of this three-legged stool. The other one was, which ties to it, would be employment. So in this case, your success is because OHSU is your employer and your trainer, and but if you had another institution that had a need, the question is, what are the ties? How are you encouraging other employers who are not necessarily union to participate in the employment? And then I'm curious about the metrics with which I know Adrian was asking about. So some of the metrics like the continuity of your students would be a key metric. At what point are they out of the program and doing something completely different that's not in healthcare? The other one would just be, what other employers would benefit from something like this? And then from an accreditation, and I'll stop because I know that Rob was asking this, it's kind of, you emphasize a lot on community college, and I didn't hear a tie to a mainstream university per se. And curious how you have looked at bringing universities and the community colleges into a room to talk about your program. Because I think the accreditation conversation, there's barriers there to entry, there's barriers to moving along the pipeline, and those would be the people who'd want to hear some of the things you're talking about and maybe knowledge share and figure out how to collaborate on helping that move forward.
Okay, so let me take the last one first. It's freshest in my mind. So we do have, Rob is one of those folks who I know from Zoom Squares. That Rob and I have had a number of conversations, and it's how we have the partnership we have, where we have 4 or 5 students going this year to Western Oregon for their master's in counseling program. And we've had a number of conversations with a number of other higher ed institutions. The HEC is actually working on facilitating conversation with some higher ed institutions so that we can have more conversation. Particularly, in our mind, we think about that CADC pathway and how there's a real opportunity for it. It doesn't make sense for higher ed to have a 90 credit program when the certifying body says you only need 15 credits. But there's a huge dearth of CADC 2s who need that 90 credits. How do we let folks take that 15 credit opportunity with us and move towards that 90 credit CADC 2 so that the state can get more CADC 1s because our pathway is faster, and get more CADC 2s because the community colleges are really training to their highest level. They're not training to a level that is somewhat beneath the community college model. So seeing more of those partnerships, we would like to really continue that, and we see some opportunities with the HEC facilitating some of that. On the employers, so OHSU is a significant size physical health provider. There are a number of the other institutions in Oregon generally are represented by another union, by SEIU, that has its own labor management training partnership, and they're doing very similar things. So they're really, I think in the acute care space, there's a lot of coverage of that. There's another, we mentioned with the CNA program, there was on the slide, there was a bullet point, I don't think we highlighted it, that some of the cohort that completed with OHSU and there were not openings, we actually reached out to RISE, which is an SEIU long-term care labor management training partnership, and we found folks placements in nursing homes. So we were able to move between the labor management training partnerships and continue to have folks in that space. And we've actually been thinking then about not just the institutional long-term care, but even some of the home-based opportunities and how that fits in. And so we've been collaborating with those other labor management training partnerships. The third piece, I think, on the participants, Maeve wanted to jump in.
Okay. Oh, you pretty much covered it. I was just going to quickly speak. I think the question had been asked about how we identify more employers, and also the value add to employers. So for QMHA and CADC both, upon completion, they are able to bill Medicaid for services. So I think we have our best partnership with organizations that are looking to expand their billing capacity. That's also where people are able to immediately advance their careers. So I think something like 25% of our QMHA apprentice graduates came from Cascadia Behavioral Health, because at that organization, their setup is such that once you get QMHA, you immediately get a $3 an hour raise because you're now billing for services. So in speaking to other employer partners, I think that that type of setup is the most natural fit. But in this environment, there's also been substantial interest from places that are not currently billing in creating that setup. So having that value add, I think, has been a way that's made it a little bit easier to have both union and non-union employers on the trust. Plus, now that we have our full pathway that can take someone from a GED all the way through a master's, that's for free. That's a big benefit to offer your employees at no cost to you. So we've seen some pretty significant increase in employer interest since then as well.
Thank you.
Yeah, thank you. I appreciate all this information. It's great that you all are doing this. Clearly, we have a participation problem in healthcare training across the state. My question is about these particular programs are traditionally programs that are offered by community colleges. And so my question is, we're really well versed in the career pathways models. So I assume most of the community colleges around the state have these trainings for 15 credits that are embedded within longer certificates and or degrees. My question is, how much involvement did you have with community colleges when developing these to leverage our existing knowledge and that kind of thing? And second question, on the completion rates presented, the 65% to 22%, I'm pretty sure all of our healthcare programs have completion rates 80% and higher. So is that, you're comparing it to our total completion rates versus program completion rates?
Yes. I don't think we had that data related to healthcare programs specifically, but if we have that data, we can take a look at that. We did look initially when we started these programs, we had a lot of conversations with community colleges. There were not a lot that had 15 credit programs for the CADC, for example. There were some that said, well, we could potentially do that on the non-credit side, but they'll never get credit for that. We're never going to CPL it. We're never going to let it continue on to an associate's degree. And, from our perspective, that didn't help. I think there may be one community college at this point that has a 15 credit, actual 4 credit CADC certification program. I think it feeds into a QMHA. The OHA is doing a pilot around the qualified mental health associate, which is more flexible than the CADC. The CADC instruction is very prescriptive. There's a basket of 6 courses you need to take. QMHA is much more flexible. And so what some entities, including us and some others, and community college are looking at is how do you use the CADC pathway towards a QMHA, which works particularly for folks who are starting out in addictions and want to really understand both the SUD issues and mental health issues that someone might present with, but might not necessarily work as well for someone who's less focused on the SUD side in the first place. But that is, I think, one opportunity at one community college where they really are focused on the minimum of the certification requirement and then how you fold that into an associate degree.
I just wanted to thank you so much. Such an amazing presentation, such amazing work. I got a chance to go last week and visit the Salem Kaiser Career Technical and Education Center as part of the Oregon Workforce Talent and Development Board had their quarterly meeting there. And the principal, Rhonda Rhodes, mentioned how you're a training partner with some of their behavioral health career pathways. Their students are graduating with QMHA certifications. And she mentioned that at least one student had graduated with a QMHA certification. So that's amazing for a high school student to be able to get that sort of preparation.
The program gets folks 1 year towards the roughly 3 years QMHA requirement. So it accelerates their ability to advance, for example, through the apprenticeship or through some other way of getting the QMHA. So that student must have had some other experience that got QMHA.
Got it. Okay. Yeah. But yeah, no, thank you. I mean, I was really impressed and with that center and your partnership. And I know you're partnering with other high schools as well. So I'm curious if you could say a little bit more about the credit for prior learning. I think you've done amazing work in that space. What are some of the other barriers that you're seeing that you're having trouble breaking through?
Outside of credit?
Yeah, well, in terms of being able to get credit for prior learning, for example, there are accreditation barriers, right, to being able to get, for someone to get credit for prior learning, for example, to go on for a master's for social degree, right? If you could say a little bit about that.
At the master's level, it's, I think, more complicated by the expectations of accreditors and by KCREP body that they have much more limited, much more limits on what extent you can use credit for prior learning to accelerate the program. The social work side in particular, you really need a BSW to get advanced credit towards the MSW. And to a certain degree that the CSWE kind of limitations in that area, to throw 3 different acronyms right at you. The Council on Social Work Education limits on credit for prior learning really being only in the bachelor's of social work context is why we see more flexibility on the counselor side, because that there isn't national limitations for the MFTs and LPCs, the counselors and the marriage and family therapists. And so there is some opportunity to get some of that master's level learning done in a bachelor's context, which we see as maybe the most hopeful way to accelerate master's prepared completion. And so when we had the slide about the community college opportunity, we think that beyond just thinking about the CADC2, we think they're really in an applied baccalaureate context. Community colleges could be looking at including the opportunity to have 500 level coursework taken at a 4-year institution, applying towards the major so that folks complete some of that coursework during their 4-year pathway and therefore accelerate their master's pathway. So it would involve partnership between the 2-year institutions and the 4-year institutions so that folks can take those classes towards that associate's degree completion. Is that some of what you're talking about? Yeah, I think I think that would be a great opportunity for collaboration within HEC partners to be able to see more folks completing their master's degree more quickly.
That's super helpful. I had the opportunity last week to attend a semiconductor workforce related workshop. And one of the things that they were talking about at Austin Community College was a partnership where engineering students that were on bachelor's or master's degree pathways would complete sort of a 4-week certificate program specific to semiconductor training, and the coupling of that technical certificate with their advanced degree was something that they were really excited about in terms of not only job placement, but competitiveness in the work environment. And so your comment made me think about that. I think some of those creative pathways, not only to acceleration of credit attainment, but also how we're coupling technical and baccalaureate learning are creative pathways to addressing some of these needs. Okay, Cheryl and then Heather, and then I think we're probably going to wrap up.
Okay, thank you for your presentation. I have some familiarity with your program and worked with an employer, a behavioral health provider, who was one of your participants and was singing your praises. They were really happy with the program, and I think they were participating in the QMHA and CADC pathway. And I had recommended United We Heal to another employer, and they had said, we met with United We Heal and we have non-represented staff, and essentially had said it would be a threat to us to participate in the program. We'd be really concerned about that. Really saying, you know, we're one of those Medicaid providers, like you had said, Andrew, that really is operating from kind of scarcity chronically. And I'm wondering how you kind of talk to employers who are behavioral health providers about the BH pathway when they have non-represented staff, and how you recruit those sort of employers when they have concerns about participating in the program.
So I'll turn it to you in a minute too. But I would say before I turn it over to Maeve, we have a number of completely non-union employers. But all of the employers have non-represented staff, and many of our participants are non-represented. So it really is not, you know, it's the trustees actually had some discussions about what does it mean to be a union employer? And, you know, be 2/3 of our workers, does that mean we're union? If it's half, like, what is that cutoff? And essentially the decision they made was that they're calling represented employer an employer that has any represented employees, but most of them, it's not even all of the non-supervisory folks, but we've also had some participants who are supervisors when they start, and other participants who become supervisors mid-program and, you know, get a promotion into a non-represented position and continue on. I think that from our perspective, there's no reason why a non-union employer couldn't participate, and we've had folks who are completely non-union, employers who are completely non-union participate.
Yeah, I think particularly in the addiction services space, there's a lot of private businesses. We have a couple of them on the trust as well. I think in my conversations with employers, sometimes people hear that it is a union project and they get very spooked because it's their perception that that could lead to something very bad for them. I think a couple of ways that we overcome that are, one, having them speak to an employer representative at either a union or non-union site on the trust. Some of the trustees are very willing to speak with people. I think especially when we go and we explain programs, many times I've heard from employers, union, non-union, whatever, this sounds too good to be true. Like, what is the catch? And then I think people think like, oh, because it comes from the union, that is the catch. And then everything that you have to say to someone about how we have mixed represented and unrepresented sites on the trust kind of just is in one ear and out the other. So if people are willing to speak with managers who are involved in the trust, I think that's a really great way to gain trust. If you're like, oh, you're the head of HR at this big behavioral health organization and you're involved in this, you're willing to talk to me. I think that has helped instill some trust in them as well. And then, yeah, I think just the longer that we're around, honestly, I think the less freaked out people are once they've realized that this is legitimate and we are offering what we say we are and there really is no catch. I think people tend to come around. But yeah, like people hear union and they get freaked out. But I was a member leader for a long time. So I very much believe that unions create stronger workforces that are better for employers. But that's not the official position of the trust.
Okay, there it's working. So thank you for the presentation. You guys are doing great work. So we really appreciate the pathway that you're creating and all of that. And I think I was just thinking about the work here in the HEC that we're doing and thinking about the multiple pathways of both the federally registered apprenticeships and then our other pathways of non-federally registered apprenticeship programs that are across the state, and how can we take a look at those? So I really appreciated Janet's questions around costs and having that opportunity, because we need to develop so many workforce opportunities, and I think no program fits the needs of everyone. So I was really, you did a great presentation today and I appreciated that. But I do think it is interesting on the CADC and the Qualified Mental Health Associate road that those are really diverse pathways, and that we do have that board, particularly for the CADCs, that, as you mentioned, trying to wrangle that hurdle, that requirement is much, much lower and can be achieved much quicker through federally registered programs, which we have many in the state. And I do think there's quite a few more than one community college that has 15 credit hours. So yeah, so something to look into. I think those are all really good points. I like the questions that folks brought up here in the HEC, because I think those would be ones I'd be curious to get more answers to, and so that we have a more solid footing of our understanding of what's available across the state. Because yeah, and I know our members in Oregon Council who participate with you guys really love the program, and it really meets those unfunded gaps that have made apprenticeship programs pretty unsustainable over the history of behavioral health, because we just don't have ways to fund the needs of the students so that they can move forward. Finding funding for this time that's actual classwork time, and then finding funding for those supervisors. So I think your program has done a nice job of filling those gaps and making it a little more sustainable for the moment. So that's great. Really appreciate it. Thank you.
Thanks, Heather. It's the perfect segue. I was just going to say, you know, this consortium is a convening a shared leadership model, bringing together employers and industry leaders, community-based organizations, and education and training partners. And it functions as an advisory body to the Higher Education Coordinating Commission, the Workforce and Talent Development Board, really intended to be that sector-focused lens around preparing workforce and talent for the healthcare sector. And so I just want to give you closing remarks. If there's one thing that you would want this consortium to take away as we continue to look for ways to increase access to and success in both education and employment for the healthcare sector, what would that be? How can this statewide lens and partnership, one takeaway, give you each the opportunity?
You look like you have something.
Maeve has something to say.
I definitely think it's vital to include workers in the conversation from the job. I think when workers have a strong sense of ownership over the programs, like they're involved in advocacy, they are the ones who feel that they've created the programs through their feedback to whatever organization is doing them. That's when you're going to have, I think, the most success. It's great to bring employers together. It's great to have CBOs, advisory bodies, but I really think that you need to be engaging workers from step one if you want to see success.
Yeah, it's great what Maeve said. I absolutely second that. I think creating these accessible pathways are astoundingly important. I think that specifically the work that we have done to reach certain priority populations, these are pathways that are not normally accessible to these folks. Traditional pathways are as accessible. They are a much more they're not as cost effective. A lot of folks go into deep student debt for these things. And so I think these pathways that are accessible that not only assist in like tuition coverage and curriculum coverage, but also offer a livable wage in addition to wraparound services in this model that that Andy and the United We Heal have created. They just make education possible. And when education is possible, and we are returning those folks into the Oregon workforce, we're going to see longevity and retention of folks working as CADCs, working as mental health associates, which we deeply need in this state. So thank you.
I would say real stackability. And I think about what that means for people who are in those jobs, who are, mental health aid ones in a residential setting and trying to figure out how to become a mental health aid two, get their QMHA so they can get a $5 an hour raise. And what those folks are who are thinking about, should I become a medical assistant? And where does that take me? Because it's not going to take me to become an RN directly. But what are those skills that I've learned that I'm going to be able to translate to, if it's respiratory therapy or radiology, in a way that's time efficient for me to advance my career in a way that's sustainable for me so that I can continue to feed my family, pay my rent. That we need to think about what needs to change in those, in the second tier educational pathway requirements that would accept more of the initial training completion and learning outcomes that have been achieved. So more of that flexibility to allow more stackability to actually occur.
Great. So engaging students in program development, accessible pathways that include tuition supports, wages, and wraparound supportive services, and thinking about acceleration strategies and true stackability. And those all sound like things that we are working on as a consortium. So really, really appreciate your time today. This was a very engaged discussion. Your presentation was excellent. Thank you for your time. Consortium members, we are going to take a 10-minute break. Please refill your coffee, grab a snack, and then we'll dive into the profiles. We are still at quorum, so we'll be able to advance those. Look forward to the discussion. All right. As folks are refreshing their snacks and coffee.
So I'll draw your attention to a couple things. Well, first and foremost, the United We Heal slides will be available with meeting materials online shortly. So a number of you asked if the slide deck was going to be available. We will get that posted to the Consortium meeting materials page so that you have access to that. Secondly, in your packets, you have the next series of slides that we're going to walk through. So you have those available to you. And then the full profile packet, which is what we'll be moving towards taking action on here shortly. As a reminder of our consensus-based decision-making approach, I think it's just always good to start with a reminder of why we have embedded consensus-based decision-making in our work. The intention is to ensure that all members of the consortium have equal voice, equal agency to contribute to the discussion. It's sort of the bedrock to our work advancing this shared leadership cross-sector model in the consortium. And so how long ago? A year and a half ago now, introduced this consensus-based decision-making tool that the folks at Oregon Consensus brought to us. It feels like forever ago. But as a reminder, your green card is I agree with and support advancing the action item as is or with amendments as presented. The yellow card is we need to pause. I need to check in. I have some questions, concerns, and we will make space for discussion. The red is I need us to reconsider and we really value coming to that with a solution. So if you're raising a red card, I just really want to encourage you to say, this needs to be changed. I can't agree with this, but here is what I recommend as a replacement. So that is our strategy. But what I want to do first is walk you through some slides to share with you where the consortium team has evolved in our own thinking over the last 6 to 8 months as we've been introducing the wage and occupation profiles. So let's see if we can do this slide, please. Going to. All right. So first and foremost, we heard a lot of feedback from y'all about questions about terminology and questions about the background and purpose for the work and the approach. And so what you will find now in the packet that's in front of you is an executive summary and table of contents. This will be consistent across all 3 of the sector packets. So we'll be advancing the same information, but in technology and then in manufacturing. You then have occupation profiles for the highest demand occupations in the sector. And we'll talk a little bit more about what's included in those next. There's a glossary of terms. So in your packet, you will find a glossary of terms that support the terminology that's used in the profiles themselves. And then in the appendices, we have included a full wage and employment data table for all high-skilled occupations in the healthcare sector. So that is included in this packet. And then we have additionally included a methodology statement from our colleagues at the Employment Department. As we've talked about, this is publicly available data through the Employment Department and qualityinfo.org. And so many of your questions about methodology are really embedded in the way that Employment Department approaches their work. So we've included their methodology statement as an appendix. And then we've also included the Oregon Employability Skills Summary in there. This is a product of the State Workforce and Talent Development Board. When we removed the knowledge, skills, and typical work activities from the profiles, one of the questions we heard across all the consortium were, are there sort of foundational skills, employment skills that could be included? And Dr. Bennings, who serves on the WTDB and is a member of your leadership team, said, well, here's this really great existing tool that we have available to us that provides us an opportunity to link to the work of the Workforce and Talent Development Board. So you will find the Oregon Essential Employability Skills Summary as an additional appendix that is, again, not sector specific. All right, next slide, please. So I want to also draw attention to some of the feedback that we received in terms of the occupation profile content itself. So first, this consortium had a very robust discussion last time we met about the audience for these programs. First and foremost, the statute, the legislative requirement is really around providing information to education and training providers and work-based learning training participants to increase transparency about employment opportunities, wage progression, and education and training requirements. So that's sort of foundational. But what we heard loud and clear across all three consortium is these really are tools for policymakers, program development, program administrators. And I would add to that the industry consortium themselves. And we're going to talk a little bit today about how we're envisioning these as a tool for what's next for the consortium. So we've really refined that audience. Will these be used for students, learners, and training participants? Potentially, but we're not going to think of them from a design perspective as the end user. The next thing we talked a lot about were the education requirements. So you may remember that section of the profile said education, I think it said education requirements. We've changed it to say education and credentials. Additionally, it initially had minimum education requirements. We heard loud and clear that Oregon Employment Department's typical education requirements is not the same as minimum. So we changed that to reflect the terminology from Employment Department. It's included in the glossary, but we've also added a note on the profile itself that typical education requirement does not equal minimum education requirement. In addition to that, we talked quite a bit about registered nurse and that occupation we were together. I want to draw your attention to that in the packet now. We have added a minimum education requirement statement there that's pulled directly from Oregon administrative rules. So it specifically points to what is required to be an RN in the state of Oregon as a minimum requirement. So that is unique to the registered nursing occupational profile. You will not see that in any other profiles, and may be something that we want to discuss here today. Let's see. I think those are the big changes around education requirements. We've talked a lot about program information. I think I've shared this with you in the past, that we don't have a comprehensive way to communicate program availability across post-secondary education and training in Oregon. We felt very strongly that if the HEC was publishing something, it had to be comprehensive. And because we don't have an easy way to do that, we have not included program information at this time. What we would like to propose, and we're going to look at this in a moment, is that as we identify a couple of priority occupations to dig further, that will give our consortium strategists some direction to start that landscape assessment, to really identify what are the programs that are available across post-secondary education and training. So that includes community colleges, that includes public and private universities, that includes other training partnerships and providers, local workforce development boards that have priority sector strategies in their regions. Those are all things that we're going to start to develop, but are not included at this time.
And then lastly, the format has been sort of tweaked and updated as we've received feedback from you all. For example, removing the skills and typical work activities. Next slide, please. So the other thing that we've been working on is really honing in on the purpose and objectives. I think we have had a lot of discussion about why are we doing this, if it's really to meet a legislative mandate, or are there other opportunities through this work? So this is how we've synthesized the feedback that we've gotten and the way that we as a consortium team are thinking about it. First and foremost, our legislative mandate is to publish wage rate standards by locality for each skilled occupation within the consortium sectors. So for you all, that's healthcare. And really what we have sought counsel from you all about is what else, how else can these be useful? And so what we're really thinking about as objectives for this work, and this is where these as a foundational tool for you all as consortium members becomes really important, is how can we use the wage and occupation profiles to really focus in on supply and demand data gathering. We've talked a lot about how do we integrate what we know about workforce supply and workforce demand. And we can start to do that with a really focused lens by prioritizing a couple of occupations. Secondly, we've talked about career growth opportunities, whether we call that, I think United We Heal referred to it as a lattice. I've heard a career matrix. I think we're avoiding career ladder because that implies a direct pathway. My team will laugh at me, but I like to talk about roundabouts where there are on-ramps and off-ramps throughout our career. And so we're thinking about what are some infographics that we can create to really articulate that. Again, informed by identifying some priority occupations where we can start. Talked about the program inventory, also a skills inventory, and then synthesizing these outputs into something that we're calling opportunity maps that really do take wage and employment information by locality, that take career and credential pathway mapping and program availability, and build that all into one tool that we can use to really articulate the opportunity for a particular occupation. Next slide, please. So some examples of where this might take us. We thought it would be helpful to show you some examples. These come one from healthcare sector, one from the semiconductor, but some examples of how this work is playing out in projects. From the Semiconductor Consortium. So this is convened by the Oregon Business Council and in partnership with the HEC, very similar to this, but convening employers, community partners, and education and training providers, specifically for semiconductor workforce pathways. And they have developed a supply and demand chart, as well as a growth opportunity infographic that we thought we'd share with you, again, as examples of what's possible. So next slide. So this is an example of the mapping of degrees to roles and sectors for semiconductor. And really what they're looking at is in the college and university degree pathways, what roles are those degrees and credentials connecting to? And then what sector of the semiconductor industry are they connecting to? This has been used on a number of occasions by the consortium to really identify gaps, either in programming or supply, workforce supply, as well as to identify opportunities. So thinking about where should we be focusing our strategies to address the workforce demands in the semiconductor sector. Next slide, please. Another example of career growth opportunities. So again, this looks at the primary degree and credential pathways. It has a illustrated upskilling path, and then the typical positions that are affiliated with each of the education pathways. So another way to look at that career and credential mapping. Next slide, please. Okay. And then the behavioral health talent assessment, which you all sleep with under your pillow, I'm sure. But just to draw your attention to a couple of tools. Next slide. AHP produced this fantastic labor supply chart. So this at enrollment across the community colleges and public universities. Again, this data is provided by the HEC, but looked at over the last decade, what do we see about enrollment? This is, of course, it's not going to tell me. I think this is program completion rates, not enrollment, but I might be wrong. But you could do it for either, and then looking at percentage changes. So this tells us some really interesting things about significant decreases in behavioral health pathways at a couple of community colleges, significant increases at some community colleges and some public universities. This table raises a lot of questions. Why? What is there something that the college or university has done to either emphasize that pathway or redirect from that pathway? So a table like this for a particular occupation or degree pathway can tell us a lot and also a lot of questions for more exploration. Next slide, please. And then you all, I'm sure, remember this amazing career and credential map with it, which is getting a lot of road miles. And this is just a snapshot, but as a reminder, it's the certifying organization, the license or credential that they provide, and then the career to which that is connected with a colored pathway map that identifies what the degree or certification is required. Remember, that's like the full map is like 7 pages long, but it has really helped to articulate in a visual way the licensing and credential pathways. So those are some examples of where your consortium team, oh, there's one more, the skills inventory. So you may remember the behavioral health talent assessment. One of the things that they found, those 7 pages of licensing and credential pathways, there were some really foundational skills that were common to all of the occupations or license or credential requirements. And so this is an example of a skills inventory that AHP conducted through their research. So those are some examples of things that we at the HEC are excited to dive into, and we really see these profiles as a way of giving us the foundational information that we need to launch into this kind of work. And we'll be looking to the consortium to prioritize probably 2 occupations that we can really start to dive into in these ways. And then we'll just build on that. So with that, I am going to pause and see if there are any questions about this, and then we can launch into the profiles. If nobody's going to say it, I want to make sure this resonates with you, because we had a really robust discussion about audience and what's included and why are we doing this work and why is this important. And I want to make sure that the way that we're articulating this and what the team is thinking about next is meaningful to the work that you all believe that you're here to do. I have a green card. Are you raising your hand or are you affirming?
Affirming.
Okay. Did you want to say?
I can mention something. So I primarily support K-12 or the high schools in Oregon. So this kind of work is great foundation. So we can make sure our schools and our regions in Oregon who provide career and technical education know the in-demand healthcare jobs and the wages. And that's one of our foundations in education, are ensuring that these careers are high demand, high skilled, high wage. So this is great foundational work for my work at least.
Yeah. I'll final say something. Yeah, along with Liz and the great partnerships of preparing and making young folks aware that there is a behavioral health career outside of sitting in a single shingle private practice, and that we have a vibrant and emerging opportunities for jobs. This is super helpful to, one, really start diving down and prioritizing, like I think we're going to do for Oregon Council for Behavioral Health members. Really, which positions are hardest to fill? How do we encourage folks who are really interested in working in a high-paced, high-acuity or crisis kind of EMT environment versus folks that we had traditionally aligned to recruiting that were more interested in private practice, working with low to moderate acuity folks. So how do we shift the system? And then also, I mean, just from an association perspective, this data is super helpful to help us advocate for improving wages for degrees that really appropriately require a high level of training and on the ground training, both educational and on the ground training, because of the seriousness of the work in saving lives. Because we know if we do not have high quality master's level folks and doctoral level folks, that and at all credentialed levels, that there is a risk of suicide, there is a risk of overdose, and people do die if they receive services that are not effective and timely. So I think it's really great. Appreciate it.
Yes, I lost all the microphones.
I love data, and I just remember at the beginning of this whole thing, me saying we need data to make data informed decisions. And so this excites me because it's really hard in Ignosium to know which hole you're filling. And there was one slide where you had that kind of had high school, apprenticeship, and then you go like this and like that. And thinking of like the panel we just had, you could see they're plugging a hole in that lower level high school kind of pathway. It would beg the question, given that nursing has been such a problem, what is this consortium doing with the nursing demand, which would be a very different solution than what United We Heal is filling. And so it would be good as we use the data to inform different things, is also to see what solutions are we as a workforce here advocating for and which hole are they filling.
And to your point, depending on the
occupation that we're building this opportunity map around, it's going to look different. Yeah.
I would say, this is a long time coming in terms of putting this all together, and wow. So I'm excited about it because especially when you talk about, the opportunity maps, and I think of business, industry, workforce, education, K-12, when I think of all of those areas that will be comprehensively tied together to, one, demonstrate we need each other. This is an ecosystem of creating a better living and opportunity for Oregonians. And it's more than just one thing. Yes. And also when I think of Portland Community College, one of the newer things at our college that I also see other community colleges starting to do increasingly, not just in the state, but across the nation, is we have recently gone through a program sustainability review in terms of, we assessed all 95, 96 of our programs in terms of not only the return of investment, but the student outcomes, the job demand, and the future job placement opportunities. And so we've had some outcomes from that recently. So this will tie very well to that. We're also doing program mapping at the college. So we're in the heart of that. So I'm excited. Yes. And the data, I can't say enough about it because it will also substantiate the work that we're doing, but it will also hold us accountable, saying we are here to do this, and the outcomes speak to what we're doing. So I applaud the work and all the efforts of everyone that's been a part of this in different ways.
One of the questions that I have is just in the naming of this. And it's high skill, high wage, and high demand. And I see how these careers are in high demand, but I also am noticing that many of the careers that are in here really aren't high wage. I see things here that are less than $20 an hour to start, and I wonder about the naming of this and agree that these are very much worthwhile, needed, important, roles in the healthcare system, but wondered about the naming of it. And is that accurate?
It's a great question, Cheryl. So a couple of things. The full data table in the appendix is all high skill. Ronan's going to keep me honest. All high skill occupations in the healthcare sector. You'll see that those are grouped by occupation category. So I think we've divided them by, I ask Ronan these questions like 27 times a week. So you'd think I'd have them down, but they're grouped by direct service occupations versus administrative and supporting roles. Those are not sorted by high demand, high wage. Those are all high skilled occupations, which was required by the statute. What we have included as profiles are those occupations that also met a high demand or high wage threshold. And the definition for high wage and high demand, I believe, is in the glossary, and how we approach that. Now, I will name the high demand, see if I can say this right. So you will see in the packets for each of the occupations a breakdown by industry sector. So if I am employed as EMT, a certain percentage of that employment is in the healthcare sector, and then there are other sectors that employ EMTs. We took those occupations where the highest demand and highest concentration of employment was in the healthcare sector to help narrow down how many occupations we profiled. So if there are occupations that there are profiles for that you feel like don't meet definition of high demand, high wage, we should call attention to those specifically just to double check our methodology. Yeah. Right.
There's a lot of great work here that I plan on supporting. That said, I was persuaded by Melissa Unger's speech from the last meeting to say that if there are legislative mandates that are currently in place that do not give the agency the flexibility they need to do what we're talking about here and make it useful, I would love to address those.
Do you, I will ask then, I feel like I've been provided the opportunity to ask. We have taken a legislative mandate and feel like we have worked really hard to add value to that for this consortium and for users of this information. Do you feel like we have been able to accomplish that, or at least we're on the pathway to doing that?
I think you are on the pathway to doing that, but I would love if there are still things that are creating, that are not allowing the flexibility. Those are the things I'd love to address, because it doesn't make sense if we're trying to cram a square peg in a round hole.
Sure. Thank you. All right.
I just wanted to say, I appreciate the work that was put into the RN occupation profile specifically. I was the red card from last time, or one of them. And so I think that's a good start. There's one thing that I would just, you asked, I think at the beginning, that if we weren't agreeing, we would provide a solution.
Yes.
So I think for me to get to agreeing with respect to that particular one, I was looking at the glossary, and it looks like OED provided a couple of definitions, one for competitive education and one for typical entry level education, which are the things that are on the nursing one that I was challenging previously, but I believe since the level of analysis is at the state level for those, and we have regional information on the back of the profiles, if we could add to those definitions, like where it says, like looking at competitive education, for example, the verbiage across the state. So competitive education provides an indicator of what education attainment potential workers may need in order to compete with workers across. Might be a definition for me, and also for the typical entry level. If you just added it, the typical entry level education is the education across the state, or educational level across the state that ODE expects. I think that would do it for me.
Gail, do you have any thoughts? Do you have any thoughts about that? From the OED perspective?
It is, if it's the statewide one, I don't think. Yeah, did say that there could be regional variation. Yeah, like it's an indirect way of kind of calling out that statewide is so that, but it could be different.
Okay.
Is there any discussion about adding that to the competitive education and typical education, typical entry-level education definitions? Yes, Janet.
So I don't have discussion necessarily about that.
I would agree with that. Just inferring that there are going to be some regional differences. And specifically registered nurses, which because of what I do, it's the one that I'm going to read the closest. I did notice under license and certifications, it looks like there might have been a line or two cut off. So when we get to the point where we're taking a look at that, if that's something we could bring up. Also, unfortunately, I have to leave a little bit earlier today, and I know that we were having some problem with quorum. So if there's going to be a vote right now, I will vote. If not, my vote is going to be in alignment with what Dave called.
We will take a litmus test right now. I just want to point out the licenses and certification language. Yes, we did notice that formatting issue. We're going to adjust the font. I think it's just one word that got cut off because it's the same language for all of the profiles. All right. Let's take a quick check-in with the cards. So as a reminder, green is enthusiastic support. The profiles as presented. Yellow is pause, I have a question or concern to check in on. And red is we need to reconsider an item with a solution. If you just want to hold those up high. Yes, sorry, with the amendment to add statewide to those two definitions. All right, so Cheryl, let's turn it over to you. Jana, registering your green card, and thank you.
Cheryl says something really good.
It's not earth shaking. So I had one edit. So for each profile, it lists licenses and certifications. And for community health workers and substance abuse and behavioral disorder counselors, it lists that there are none required. And for community health workers, it's the OHA Office of Equity and Inclusion. And for the folks, it's MACBO. And it'll be important to list those, especially if the audience is policymakers and planners.
Say that again.
Community health workers.
Under
it's-
licenses and
yeah,
credentials.
yeah, it's the OHA Office of Equity and Inclusion.
Okay, that's who offers.
That
the
is the
license?
certification body.
Okay, so we should get a hyperlink to that.
Yeah.
Okay.
And then for substance abuse and behavioral disorder counselors, that's the Mental Health and Addiction Certification Board of Oregon, MACBO.
Okay.
So we'll want to include both of those.
We should remove the language, no statewide license required for
Correct.
certification from both of those, and add a hyperlink to the appropriate organization like we've done.
Yes. Both of them have a
in depth
certification
cases.
body.
Thank you for that correction.
They're a credential. not a
They're a
license.
credential, not a
Okay.
license. And it'll be, it's really important because those positions are both work a lot in the publicly funded system and bill insurance. And so, yeah, it's really important.
Thank you, Cheryl.
Yeah.
Yeah. If we include that under licenses and certifications, is that appropriate? Is a certification?
That's good enough.
Okay, all right.
And with that, I'm green.
With your green. All right. For the folks online, if you could register in the chat, green, yellow, red, that will help us with quorum. And just for a matter of course, if you would raise your card with the two amendments, updating the credential requirement, updating, adding statewide to the two definitions, in the spirit, acknowledging that Jana is green because Dave is green. And folks on the line are all green. All right. Well, congratulations. We've been talking about a way, like, how do we celebrate when it's consensus building and it, it feels like it's too easy to just say and move on. So thank you. I just want to reiterate the discussion that we have had at the last several consortium meetings around these have really shaped where these profiles have come. Your counterparts in technology and manufacturing have had similarly robust conversations, but they've been about very different things. So I think what you see in this product reflects some of the uniquenesses of the healthcare sector, but it also reflects what we're hearing across those three categories. I want to, and he doesn't know I'm going to do this, I want to in particular draw attention to Ronan Fitzsimons Bray, who has tirelessly been working to implement this body of work with sometimes moving target and sometimes lack of clarity about what it is that we're trying to accomplish. And he embarked on this work leading with establishing the initial methodology two years ago. And I'm certain that we'd actually have a product to share with you all at times, and also certain that he wasn't sure the product that we were moving forward was going to be foundational for additional work. And so just really want to recognize Ronan's work on this project, because it has been tireless and patient. And I'm very excited about what we've been able to provide you all today. So thank you. All right. With that, I have one more slide. It's just our next step slide. So again, thank you all for your work in getting to this point. And I just wanted to wrap us up with some next steps. Where do we go from here? So first and foremost, this meeting was supposed to have been somewhere outside the Portland metro region. We decided to push that to September. So your September meeting will be outside of the Portland, Salem area, and we are looking for ideas to go. You may remember that last year, Dave hosted us down in Medford. It was a really great opportunity to learn from regional partners and learn about work that's happening. So start thinking about it. If you have an idea or a place you really want to see and learn more about, our technology consortium next month is traveling to Pendleton to learn more about some of the drone technology work that's happening out there and some great STEM work that's happening in Eastern Oregon. So as an example of some of the other places that we can travel. That was the first thing. The next square is the opportunity mapping. So I'm going to do this by email. I believe in voting by email whenever possible. So we're going to give you this list of occupations and have you identify probably your top 3 to 5 that if we were to start doing a deep dive on opportunity mapping, and then we'll be able to register that for the entirety of the consortium and really start to focus on what's happening next. I anticipate, so you may remember we've stood up 2 working groups. We've had some agile working groups in addition to that, but really our priorities have focused on nursing demand planning and behavioral health, workforce development. And those still remain priorities, but I think we're thinking about repurposing those work groups to really help inform this opportunity map development so that work groups have a project to really dig in on. So depending on what occupations rise to the top, we may want to think about adjusting the work group structure. Okay, next. I think the next one is strategic planning. So the consortia strategists are starting to think about what our work plan will be for 2026. And I anticipate that at the Q4 meeting, in partnership with your leadership team, we'll be presenting some ideas for a work plan and a strategic action plan for 2026. And lastly, I want to make sure it is on everyone's radar that we are heading into the final year of project activities for Future Ready Oregon. Now, as a reminder, the industry consortia were established in statute as permanent advisory bodies to the HEC and the Workforce and Talent Development Board. Those positions, those strategist positions, are permanently funded, and that sector-based workforce and talent development strategic work will continue. But that being said, the grant-funded projects, many of which you have heard about through panels, and through our Office of Research and Data providing the annual reporting, many of those projects, well, all of them, the grant funding will cease. And so what is it that you all want to know about those projects? I will name that the Racial Justice Council, the Governor's Racial Justice Council, that is where this foundational work of Future Ready Oregon began. And the Racial Justice Council has convened a workforce work group that currently is asking some of these questions, is saying, what do we want to know about the Future Ready Oregon investments? The purpose of that investment, in part, was to identify promising practices in post-secondary education and training, workforce and talent development, in prioritizing sectors of our economy, and reporting on that to inform future investments. But you all are part of the lasting infrastructure, if you will, of the Future Ready Oregon investment. And part of your mission and purpose is to be able to articulate those lessons learned, proven practices, and continue to use them to inform in your advisory capacity. So I wanted to plant the seed today to say, project activities end this time next year, and then we wrap up administrative responsibilities by December 31st of 2026. So in the next year, which is 4 quarterly meetings, what do you want to hear about? Are there particular grant projects in the portfolio? Remember, we shared with you the entirety of the healthcare portfolio. And if you don't have that readily available to you, it is available in your meeting materials online. Are there particular projects? Are there particular approaches? Are there strategies that you'd like to learn more about? And we can start to weave that learning into your next several quarterly meetings. All right. So I'm going to plant that seed, and I'll probably follow up with a poll, and we'll include links to the project information so that it can prompt your thinking as well. So your takeaways: where do you want to meet in Q4? Prioritizing a couple of occupations from the profile packet, and starting to think about what you want to hear more about over the next year while we have Future Ready Oregon projects going. Yes.
Question that's a little adjacent to this, but we've and I understand why we've missed Kyle the last couple times, but I think we need to know from the governor's office what they're planning for federally. You know, in the next 2 weeks, we'll know what's happening with Medicaid. And that, I think, is just the first massive thing to happen. I think we cannot plan or know what we want to do, understanding that or not understanding what's going on federally with some of this funding. So I would, if we could even get an email update post, congressional approval of what's happening with Medicaid, so we kind of have an idea of what's going on, that would be great.
That's great. And I'm not sure whether that would be Kyle or Sarah, or someone else in the governor's office. So, Rona, we'll make a note to follow up with them to get an update for y'all. Yes.
Real quick, related to that, I was hoping we get an update on workforce development funding that came out of this legislative session. I knew there were some things in the work, but maybe others know more, but I don't know where any of that landed. I don't know if you could give a real brief synopsis or if that could be included as well.
We can absolutely include something from Kyle. I appreciate, you're right, he did miss the last one because he got called into a committee meeting as well. What I can provide at a really high level is that the HECS budget was funded essentially at current service level. You may remember, particularly for this group, that governor's recommended budget, there was an additional investment in behavioral health, workforce development. That is not included in HECS budget that is advancing. And I think just in this revenue environment and with some of the uncertainty that Brian and others have noted, I don't anticipate that there will be additional funding. That being said, HECS budget is moving through Ways and Means at essentially a current service level.
Thank you.
Yeah.
I don't know if this is the update you were asking about, Brian, but if it's CCO 3.0 procurement, it was delayed by 2 years. So the next CCO contract will begin in 2029. I don't know if that's what you were asking, but.
In part.
Yeah, in part.
Okay.
The Medicaid cuts is that's the big one.
Okay, so we'll get an update.
Whether
on
we even have a
Medicaid.
waiver.
Yeah, we'll get an update on Medicaid. We will get an update on, there are some other nuances with HECS budget. I want to make sure we can capture that in a follow-up email.
Yeah, and for behavioral health, it'll be the second layer of will be the reorganization of SAMHSA. And I guess for state, we would call it the POP, but the executive branches also will have to, outside of the BBB budget that Brian's mentioning, that will be another layer for us to consider. Probably it might get pushed out again for another 3 months, maybe January next year, to know what, because that funds the block grants to states for mental health and substance use, which significantly impacts our sector.
That's super helpful. What we will do is send an email to Kyle and Sarah. We'll get some updates for y'all. We will send that out. I don't know if this is important. We typically include you all as a blind copy, just to avoid the temptation to reply all and break public meeting laws. So watch for that. We'll get updates from Kyle and or Sarah, send them out to you all. But what I do want to encourage you, do feel free to reply to that email with any additional questions or clarifications. We can then share that with Kyle and or Sarah and share that back out with everyone, so that again, we're making sure we're sharing information to all consortium members, but avoiding dialogue outside of public meeting. Did you have another question or comment?
I was just gonna say, there is 17 million for Oregon Essential Workforce Healthcare in the Christmas tree bill that just came out. So I don't know if that was what was missing, but.
I don't have the details about what that is, but it is not the behavioral health investment that was in the GRB. But I will get more information for sure. All right, super. Well, I think
I think I'm still letting you out 10 minutes early. I'm giving you the gift of time. This has been a great meeting. I appreciate everyone, particularly those of you who have traveled a ways to be here. Oh, another important announcement. I did just confirm. We have extended the recruitment for the healthcare strategist to Monday, the 30th. So I know I was delayed in sharing the announcement with you all. But now we've got just about an extra week. So if you are inclined, please do share that opportunity with your networks. And it's a privilege to work with you all. So I'm excited to see who we can move into that position next. But thank you again to all of you. Again, those of you who traveled to be here, those of you joining us online, we do appreciate your time and wish you well and safe travels.